बात करेंगे aortic stenosis के बारे में। सो aortic stenosis, तो अगर एग्जामिनर हमें क्वेश्चन पूछता है कि आपका डायग्नोसिस क्या है तो हमें कैसे बताना है, तो डायग्नोसिस की बात करते हैं। तो डायग्नोसिस हमें कैसे बताना है aortic stenosis का, हम बोलेंगे सर दिस इज ए केस ऑफ, इट इज़ ए केस ऑफ valvular aortic stenosis, valvular aortic stenosis, aortic stenosis. So sir, this is a case of valvular aortic stenosis of rheumatic origin, without congestive cardiac failure, or we can say with congestive cardiac failure, with or without congestive cardiac failure, and whether the patient is in sinus rhythm or the patient is not in sinus rhythm. So we will say our diagnosis of aortic stenosis like that sir, this is a case of valvular aortic stenosis of rheumatic origin with or without congestive cardiac failure, and the patient in sinus rhythm or the patient is not in sinus rhythm. So after the diagnosis is over, then how will you say what is your case? Then the examiner can ask what is your case, then you have to elaborate further. So examiner can ask what is your case. So we'll see now what is our case. So we will build up our summary and we will say the chief complaints in angina are usually the exertional dyspnea. The chief complaints are in aortic stenosis is exertional dyspnea, then anginal pain and syncope. Then we will say all the symptoms occur on exertion: exertional dyspnea, anginal pain on exertion, syncope while doing exertion. Then dyspnea occurs primarily due to elevation of pulmonary capillary pressure. So dyspnea occurs because of pulmonary capillary pressure. There is rise in pulmonary capillary pressure, and also pulmonary edema give rise to exertional dyspnea. Pulmonary edema. Then anginal pain occurs due to low aortic blood pressure and low cardiac output that give rise to anginal pain in aortic stenosis. Sometimes severe aortic stenosis may remain for many years without producing any clinical disability. Okay. Then syncope, or we can say syncope or blackout. It is due to low and fixed cardiac output. Syncope occurs because of the low and fixed cardiac output. Low and fixed cardiac output give rise to syncope or blackouts. Also due to low blood pressure, left ventricular failure. All these features of low cardiac output, low blood pressure, left ventricular failure give rise to cerebral hypoperfusion. So the brain does not get enough of the blood, and that's why the patient start having syncope or blackouts. And these are the cardinal symptoms seen in aortic stenosis. These are the cardinal symptoms. So these are the cardinal symptoms of aortic stenosis. Cardinal symptoms. Sometimes the patients of aortic stenosis may brought in the casualty with sudden cardiac death. So this is our case. The patient having exertional dyspnea, anginal pain and syncope. Now examiner can ask, why do you say it is aortic stenosis? Why aortic stenosis? Then what will you say? You will say, sir, because of the presence of, you will elaborate the symptoms, because of symptoms and signs. So symptoms and signs, we will now see what are the symptoms and what are the signs. The examiner will ask why aortic stenosis. You will elaborate the history of symptoms, that this patient is suffering from pain, chest for 1 year. This patient is suffering from pain chest for 1 year. Then patient also suffer from exertional dyspnea from 9 months, and patient also have blackouts or syncopal attack from last 2 months. So these are the symptoms you will say the patient having the chest pain, exertional dyspnea and blackouts from last 2 months. Plus, if there is a positive history of rheumatic fever, you will say that there is a past history of rheumatic fever. So these are the symptoms my patient is having. So that gives a clue towards the aortic stenosis. Then you also say the signs. You will now elaborate what are the signs you will find in your patient. So we'll discuss now what are the signs in aortic stenosis in our case. So signs. The signs, you will first tell about the pulse. You can say the pulse is 72 beats per minute, regular, no radial delay, no radiofemoral delay, arterial wall is not thickened, arterial wall is not thickened, arterial wall is not thickened, and all peripheral pulses are palpable. All peripheral pulses are palpable and of anacrotic in type Anacrotic pulse is also called as pulsus parvus it tardus. Pulsus parvus it tardus is an anacrotic type pulse we are getting in this case. Sometimes you can get carotid shudder. Carotid shudder. It is basically a systolic thrill in the carotid artery. Systolic thrill in carotid artery. So these are the findings you get in your pulse. So you are getting 72 beats per minute of pulse, which is regular, no radial delay, no radiofemoral delay, arterial wall is not thickened, all the peripheral pulses are palpable and of anacrotic in type, that is pulsus parvus it tardus. If you get a carotid shudder, you will say there is a systolic thrill in the carotid artery. Then after the pulse, you will tell about the blood pressure. So you will tell about the blood pressure. You will say the BP or the blood pressure is low, say 90 by 65 millimeter of mercury. So the blood pressure is low with low pulse pressure in supine position, with low pulse pressure in supine position, with low pulse pressure. So this is about blood pressure. Then about the apex beat. So about the apex beat, you will say apex beat is heaving in character, and the position is normal in position and heaving in character. The apex beat, normal position, that is half inch inside the left mid clavicular line, half inch inside the left mid clavicular line, that is normal position of apex beat in aortic stenosis and heaving character. Then you also say there is no palpable heart sound, no thrill in the apical area. No palpable heart sound, and no thrill in apical area. Even though there is left ventricular hypertrophy in aortic stenosis, apex is usually not shifted. Apex is usually not shifted because aortic stenosis causes concentric hypertrophy. Even though aortic stenosis causes left ventricular hypertrophy, but the apex is usually not shifted because aortic stenosis causes concentric hypertrophy. So this is about the apex beat, heaving in character, normal in position, no palpable heart sound, and no thrill in the apical area. Then after this you will tell about the palpation of the aortic area. Palpation of aortic area. Palpation of aortic area, you will say you will get the systolic thrill. You get the systolic thrill in aortic area, and this is best felt in full expiration. Best felt in full expiration. Best felt in full expiration with patient sitting and leaning forward. With patient sitting and leaning forward, you are getting the systolic thrill in the aortic area. So in the aortic area you will get the systolic thrill, which is best felt in full expiration with patient sitting and leaning forward. This thrill may radiate to carotid artery. Radiate to carotid artery. Carotid artery. The thrill radiates to carotid artery. Then after that, about the auscultation of heart sounds in the aortic area. So auscultation of the aortic area. Auscultation of aortic area. You will say S1 is audible, S2 is muffled, S1 is audible, S2 especially A2 is muffled. Ejection click present. Ejection click present. Then you will elaborate the murmur of aortic stenosis. You will say a harsh mid-systolic ejection murmur of grade 5 with direction of selective propagation. With direction of selective propagation towards the carotid is heard. So you will hear a harsh mid-systolic ejection murmur of grade 5 with direction of selective propagation towards the carotid is heard. The murmur is best audible in full expiration. The murmur is best audible in full expiration. So this is important. In full expiration you are getting the best audible murmur. And also with patients sitting and leaning forward. Sitting and leaning forward you are getting the murmur, best audible. And with diaphragm of stethoscope. Diaphragm of stethoscope. Occasionally, sometimes what happens, the murmur of aortic stenosis is transmitted to mitral area. The murmur of aortic stenosis is transmitted to mitral area, and it is known as Gala-Verdin phenomena. So it is known as Gala-Verdin phenomena. So this is about the auscultation of aortic area. You are getting S1 is audible, S2 especially A2 is muffled, ejection click is present, a harsh mid-systolic ejection murmur of grade 5 intensity with direction of selective propagation towards the carotid is heard. Murmur is best audible in full expiration and with sitting and leaning forward and with the diaphragm of the stethoscope. Murmur of aortic stenosis is sometimes transmitted to mitral area, and it is known as the Gala-Verdin phenomena.